Hi, everyone. Lots of folks are still joining us, so I'm just going to wait for another 30 seconds or a minute, and then we'll dive right in.
Good, Monica.
So good afternoon. In the interest of honoring your time, I see some folks are still joining us, but I'd like us to get started. And so welcome to this month's conversation with the Vermont Department of Health and the Vermont chapter of the American Academy of Pediatrics. I'm Brenda Metzler, a community and program support specialist with Let's Grow Kids, and I'll be your host today and manage incoming questions. Please know that any of your questions relating to healthcare in Vermont's early childhood education settings that go unanswered in the next hour will be collected and sent to today's panel for written response, after which we will email their responses to you. Here in Vermont, we are so fortunate to have direct access to healthcare experts who work on our behalf. Let's welcome and give them our attention. Dr. Brina Holmes comes to us from VCHIP. Welcome, Brina. Molly McClintock is an RN with the Vermont Department of Health. Katie Leffel is also an RN with the Vermont Department of Health. And Brina, Molly, and Katie will be answering the questions that you submitted when you registered. I'm also pleased to introduce Monica Ogilby, registered nurse and Vermont's Immunizations Program Director. She's going to tell us today about Vermont's robust preparations to roll out the COVID immunizations for young children as they become available. And finally, Sally Kirshner is an RN with the Vermont Department of Health as well. She has been bringing us accurate and up-to-date information, health information throughout the pandemic. But today is Sally's last conversation with us. She has retired and is going to devote her time to other Vermont healthcare initiatives. Congratulations on your retirement, Sally. If you look carefully, you'll see boxes in the background of her office. But you should know, Molly and Katie are committed to continuing these conversations as part of their mission to offer statewide support for maternal and child health equity. Please note that the November date for our regular health conversation falls on Thanksgiving Day. So we at Let's Grow Kids will work with Molly and Katie to determine another date. If not in early December, then for sure in January to talk with you again. So stay tuned. And now I'm going to turn it over to the panel to bring us today's information.
So hi, this is Sally Kirshner, and it just Brenda did a lovely introduction for us, and so we will move right over to Monica, who is the Immunizations Program Director here at the Health Department at the state of Vermont, and she has updates on the vaccines in children efforts in Vermont. So next slide. And we said that, so we're always glad to talk with you folks. So here's Monica, and Monica, you may realize Rhea will advance the slides for you. Okay, and Monica, are we hearing you, or we're ready for Monica?
We still can't hear you.
Mysterious. This is Brina. Monica's mouth is moving.
Well, it looks like
I'm
Monica.
happy to go. I can. This is Brina. I can go through some of these slides, and Monica can fill in some detail when she logs back in. How's that?
Great.
Thank you.
Okay. Thanks, Rhea. We'll go next slide. So, folks, this has been like truly one of the most exciting weeks in the pandemic to date for us as pediatric healthcare professionals, but also as people who care deeply about children. So we wanted you to see that there is a well worked out pathway that you're now also familiar with on how a vaccine gets approved. So just not to spend too much time on this, but it gets confusing in the media because FDA makes the recommendation, but then it has to, which happened there, they had a subgroup recommend this week that 5 to 11-year-olds are safe to receive the Pfizer vaccine, but that has to go to the broader FDA, which then goes to the Advisory Committee on Immunization Practice, and then the CDC decides if it's going to accept the Advisory Committee on Immunization Practice recommendation, and then the vaccine's available. So this is usually linear, but the timelines for each are sort of like a couple more days. So the state of Vermont is planning for the first week of November for this whole thing to be approved, and the vaccine will already be on its way or here in Vermont for the beginning of vaccinating children 5 to 11. Monica, interrupt the minute if you get there, but no worries if not. Next slide. She's having a thing. So this just repeats what I just said in terms of where we are today on the 28th of October, that the recommendation came out of the subcommittee this week, and now we're waiting for ACIP, Advisory Committee on Immunization Practice, which is the 2nd and the 3rd, which is Tuesday and Wednesday next week. And then we're very hopeful that the CDC director that night, the 3rd, says, yes, November 4th, let's get going. Next slide, please. So this is the part that Monica's really the expert in, because the way that vaccine comes to the state is really well worked out in a term called pre-positioning. We are going to begin with community clinics because it's easier to get all the infrastructure in place, but we are going to quickly move from community clinics into pediatric medical homes within that first 2 weeks of beginning vaccination. So we're hopeful that 15,900 doses are going to arrive, that they could come as early as this week and be ready to administer when that final CDC approval comes through, hopefully midweek next week. I like this sentence, and I appreciate Molly and Katie's roles at the health department, that we have to have equitable distribution of this vaccine. And that means we're looking very closely at how to use our schools. And when we say school-based, but I want to make sure for those of you that work with school personnel, this is really a school-located clinic, meaning that there's no expectation that school administrators are going to have to do the work here. This is a group of highly trained and ready vaccinators coming into a school already. Next slide.
So, Brina, I think that was it for Monica. And
just wanted Monica
sorry
to know we've all been there. We have all been where you are. So glad we have a team.
Yeah, so thank you for the slides, Monica, and thanks. And people saw you briefly, so they know that so you know who she is, and she's will be great in helping, and has been great in helping move this through with vaccinations for the kids in this next age group. And then as it's planned for, as the vaccinations get to children younger than 5, Monica will also be working with partners and people like Brina and pediatricians to help move that forward also. More, that'll be like in 2022, we hope. And then you folks, of course, will get more involved in that. So I'll do the next couple of slides. I have this one is, we've shown before, just kind of a, I'm seeing Monica says thanks and she's apologizes. So this is just to remind us where we were in the spring and why some questions still kind of linger, and why, but also that folks who operate childcares have done such a great job over these last many months in determining what works best in their program to keep their families and children safe. And again, you guys are always on the front line and always our best thinkers in how to keep your children safe. So this was from August. All children and staff need to stay home if they have symptoms of COVID, they have the fever, or are in quarantine due to close contact or in isolation due to testing positive. That's fairly straightforward, but as you all know, may be difficult to execute. And again, it's frustrating at that time because we didn't have vaccinations, but as we've hearing from Brina and Monica, they're coming really soon for this next age group. And that the health department contact tracers are in touch with you folks as it to investigate if you are having cases related to your childcare or realize you do have a case related to your childcare. Okay, next slide. Yeah, oops, my slides look so much, I can't tell which one's up. So this one just came out this week, and to acknowledge is from CDD, and how I'm reading this is that there's a lot of information, a lot of buzz on new policies and procedures for COVID-19 in schools, you know, kindergarten up through high school. So a lot's going on, but nothing has really changed in the way of procedures for children under 5. If something happens, of course, CDD is always in contact with people like Brina and our division director, Elisa Stahlberg, and Monica and other leaders here at the health department. So if things are changing or new logistics, of course, CDD will be in touch with you. And we can also, you know, you hear about it through emails, through new memos from CDD, Let's Grow Kids as a resource, and also the health department website, CDD website, and then Let's Grow Kids and webinars such as this. But for the moment, just, you know, keep aware of what's going on. But as far as we know, there's nothing new specifically for you folks at this time. Next slide. As we just heard from Brina and Monica, it's coming out next week. And again, to reiterate, we're thinking this is going to be a beginning of a regular vaccination process for children, just like we started out with measles, polio, pertussis, other vaccines. I'm old enough to remember when these were starting to be rolled out and became like a big thing when they came out and they were new, and then were rolled into the regular. This is how we keep our children healthy, with regular checkups to the physician, to nutrition, physical activity, and preventative measures such as getting regular vaccines. So that's where we'll be going to in the next many years as this urgent situation of the COVID is taken care of. And you folks as childcare providers can talk to the families, get the parents vaccinated, urge them to get vaccinated if they're not yet, and also get the children vaccinated. And if the families have any questions, they certainly can talk to their healthcare providers about their questions. Then the Vermont AAP does this wonderful thing. Brina, they did this in the spring, right? When the first batch for teens came out. And now another round is coming beginning November 8th. And this would be your local pediatrician working with local leaders and offering a series of webinars to families so they can log on and ask questions and hear information. So Brina, I guess I'm thinking that would be, we can ask Let's Grow Kids to notify the child cares when these are scheduled, or this is just to keep checking on the AAP website? Oh, so I think you're we're not hearing you.
Oh,
Brina.
I'm muted. Yeah.
Okay.
Absolutely. There'll be really nice question and answer community forums with hopefully familiar faces. That's the goal. And we did do this back in May. I did want to note, I don't think we say this anywhere else today. So yeah. The Pfizer vaccine for children 5 to 11 is 1/3 the dose of the adult vaccine. And those of you, I've had so much fun with you over the 18 months with your scientific inquiry as great childcare leaders, and the Pfizer data about the antibody response that children got from 1/3 the dose is really incredible. So it's sort of in the 90% effectiveness rate, which, remember, we got a little greedy with these vaccines thinking, We wanted them to protect us entirely from the disease of acquiring the virus of COVID. But remember that no vaccines exceed 90 until COVID. These are going to go down as the best, most effective vaccines in the history of vaccine in our country. And the other part I always want to remind folks, this is not new technology. That these vaccines are messenger RNA, the Pfizer and Moderna. So Pfizer is the one currently on the path for approval. And within that messenger RNA technology, that's the basis of how we're vaccinating. So it doesn't leave product in your system. It isn't new in a way that we would want more time to test the impact. It's creating a signal to your body to develop antibody that you will then have to protect yourself, most especially from severe disease and death. So much more to say about that, and I hope that you can join the forum, but it is wildly misrepresented in some aspects of our media. And I love what Brenda and others said at the beginning. This is the place we want to come together as people who care for children to get the facts right and resist the temptation to use the media to explain things to us. So it's a little editorial there, but keep going, Sally.
Right, so next slide. So then just a summary of what we've been talking about, that again, remembering way back June that we had the executive order, and then that was discontinued. So through the summer, people had the guidance, had unofficial guidance as to, and public health information as to how to work your programs and do the best to keep the children from getting exposed. In August, the memo came about the universal masking for all children and staff when indoors. Of course, not under 2, that kind of thing. Childcare programs, as you folks know, to create any COVID-related ongoing practices or policies that use the best practice, obviously following CDD regulations and the best practices in caring for our children. I'm sure some of you have worked with our contact tracing people, just by the nature that we are having cases in your childcare programs or related to the families of the children in the childcare program. So we have our health department workforce, the AM trace workers who are working with you folks. And there's just a lot of information on our website. And this is the general childcare and out of school programs webpage on our website. Next slide. And here are the resources. Just if you get on our website and start clicking around, these all come up. The vaccine information and clinic schedules, the testing sites, FAQs, the general information for families. I'm skipping over the general information for child and out of school programs. There's information about travel. We had a few questions about that. You can always call us, as you know. And also AAP has a national website that has great information. Brina, that's healthychildren.org is the AAP site, and CDC. So there's just lots of great information. Brina kind of hinted that these are the best places to go with really well-researched and tested out information for childcare providers and families, as opposed to maybe some other sites that have information that are not quite so rigorous. So the next slide. So now we get to the part, several of you have sent in questions, and our nurses, Molly and Katie, have worked on answers, and they will be reading them off and talking about the answers. And Brina, we welcome you to jump in too, to augment or make sure that we're not forgetting any key points. So I think we'll stick on this slide for a little bit while we give the microphone to Katie and Molly.
Okay, and some of these questions that were submitted earlier, like Sally said, have been partially at least addressed in previous slides, but we're going to go through them for you guys. So the first question is about travel and the upcoming holiday celebrations with unvaccinated children. So with the expiration of the governor's executive order in June, we do not currently have any travel restrictions in Vermont. The CDC recommends delaying travel until you're fully vaccinated because travel increases your chances of getting and spreading COVID-19. So continue to encourage eligible family members to get vaccinated. The VDH also recommends that if you travel to places with a lot of virus circulating or spend time with people who do, to consider getting tested and following prevention steps, even if you are vaccinated. If you are traveling internationally or some of your families are traveling internationally, they will need to follow the CDC guidance on testing and international travel.
All right, next up, we were asked when a child in our program has a sibling who is a close contact, in our case, the siblings are under 12 and unvaccinated. The VDOH indicated CDC guidance is that the child in our program could come even if the sibling is not isolated at home. When I mentioned the local school had a different policy, he suggested that schools were different and they could create a policy they are comfortable with. My concern is we have children from different districts and therefore different policies. So in this situation, it is really focusing around a contact of a contact. And so VDH does not currently have any requirements for contacts of contacts to quarantine. And VDH does make recommendations on best practices, but schools are responsible for creating their individual policies.
Can state-funded Act 166 partners be included in the new testing protocol? Oh, sorry, wrong question. What is the recommendation from the VDOH for preschool childcare programs who received Act 166 funding from the AOE? So continue to follow the advisory memo from CDD from August. If you are funded with Act 166 funds, you should work with your local school regarding their policies.
Can I just embellish briefly for Molly's response? Well, first, I really want to acknowledge those of you that work within the childcare system as well as your school system. That's been a very difficult spot for many of you for many of these months. What Molly said is accurate. Schools do have, some independence here. However, from a health perspective, there's no reason to quarantine, as Molly said, context of context. So we actually like to know about that because we would like to help the school to see that they're creating a policy that's not public health. So I just wanted to come in a little stronger there because that happened all year, that when school districts got nervous about increased cases, they started to make up some rules. It only happened a handful of times, but that makes me feel, concerned that we're keeping more students out of in-person learning by making decisions about contacts of contacts. So that's the kind of thing we like to hear about both the pediatricians in your community and the health department, the specifics.
Thank you. Next question is, can state-funded Act 166 partners be included in the new Test to Stay testing protocol rolled out for public schools? So currently, Test to Stay is only available for students ages 5 and up in K through 12 school settings. Test to Stay is not available for workplaces and other non-K through 12 settings. There are expectations that it will be most effective in settings where participants are closely monitored, follow predictable behaviors like seating charts, and will arrive on multiple consecutive days for rapid antigen testing before entering the premises.
And masking. I really want it because I know that you're all good thinkers about this. Test to Stay is a very safe, cool strategy for keeping more students in school, but it absolutely is predicated on masking. So we've had a lot of developmental conversations together about the ability for children under 3 or different ages to keep the mask on. So would have, and it hasn't been tested in other states. We built our program in Vermont on experience in the UK, Utah, and Massachusetts, none of whom have gone below age 5.
Okay, next question. Changes to the criteria for the AOE regarding close contact. So will this change for childcare as well? We have not heard anything as of yet, but the CDD will keep you informed should that change. It is important to keep in mind that cohorts are very different and have different behavioral expectations. This is sort of along what Brina was just talking about. So changes made for school-age child may not be applicable for the birth to 5-year-old population.
All right, so the next question is that I understand that schools are requesting cardiac return to activity approval. Is that needed for children under the age of 5? So nope. The cardiac screening algorithm, which some people are calling the return to play algorithm, was designed for children ages 5 and up. And it was really designed for older children engaged in strenuous physical activity, not your typical daily play.
Just wondering if Brita was going to jump in a little there, but okay. All right.
Perfect answer. That was perfect answer.
Yay. Next question is regarding the use of the pediatric flowchart for COVID triage evaluation and return to school. So this pediatric flowchart is actually meant for as a tool for primary care providers. The VDH would recommend implementing a policy that's based on the return to child care guidance, which is a separate document, regarding return to child care procedures in your program. It's also really important to communicate these expectations clearly with families.
All right, next up, how are we notified of changes to or information about COVID procedures and best practices? So the CDD will send out emails when there is a change or update that does occur. As well, you can check out VDH and CDD, keep their websites up to date with best practices, and Let's Grow Kids is also a very valuable resource.
The last question we were sent is talking about any upcoming changes regarding the mandated indoor masking. So I'm just going to read directly from the CDD memo from August 18th. So due to the fact that the population of children in childcare and out of school time is generally not eligible for vaccination, programs should require universal maskings for all children and staff when indoors. There's also an advisory memo for exceptions to the universal masking recommendations. And that was actually it for the questions that we received. Yeah.
Thank you. Thank you, Molly and Katie and Brina. And Brina, did you want to add to any of those answers before I pose some of the questions that came in while you were answering those?
No, those were great answers. I do want to acknowledge that yesterday in the press conference, the governor has extended the masking in schools until at least mid-January 18th. So I would take that as a very strong endorsement of masking for all as we continue to fight our way out of this Delta surge. The reason we're so excited this week is this pediatric vaccine for children 5 to 11 is going to be one of the key strategies to pull us out. And the timing is good because we're heading indoors more and here comes the cold weather. And so it's, you know, the light is here. And we also acknowledge that obviously most of you care for children below the age of vaccine eligibility, even when this is approved next week. But please know that as we continue to vaccinate more and more Vermonters, the community burden of the virus will drop. So you're not going to be left with the number of exposures and cases you're currently experiencing. I just wanted to use late October as a chance for some hope.
Yeah, thank you. Another nugget of hope that I heard when Sally was presenting at the beginning was that there is optimism that it might be in the, well, we don't want I guess, name dates, but that it sounds like maybe in the first quarter of 2022, we can expect the next lower, the next age group lower vaccine coming. So fingers crossed. And then there's one other thing that I just wanted to not clarify, but just say a bit more in a couple of the questions that related to hearing from the CDD. So what I know is that the CDD will send out updates when you haven't heard from them. And as a person who's operating a program, you're on the list to get all the things. So if you haven't seen something, it means that there hasn't been an update. So it's not that you've missed it. It's just that there hasn't been anything to share. And now to go to some of the questions that have been coming in live. Some of them are, sort of quasi-related to things that you've already addressed, but I think what people are sharing is their lived experience here. So someone said, if both parents test positive and no isolation is taking place, does the child of that family need to wait the 10 days plus the additional 7 to come back into our center?
You guys want me to do that one? So there's an overarching theme here. These complex individual situations, you need your advice to come from the contact tracing team in the health department, because I can start to try to answer this verbally, but we're going to start getting into the what ifs, and then you're going to, we could do a one-on-one as well. But if you're describing an unvaccinated child in a house with people with COVID and they can't isolate, meaning the child's too young to be caring for himself, or you can't send them to an aunt's house, and they're physically in the house, there's a very important calendar analysis of when was the person last infectious, and then if the child remains asymptomatic, 7 days after the infectious period has ended, they can test out of quarantine. So I can't do the math for you in the Q&A without knowing those variables. But in general, the other part that's really tricky is if one adult gets it, then the second adult gets it later, you have to reset all the way. So then you're pushing and pushing down the calendar because it's now the second exposure becoming non-infectious that starts the clock for the 7-day test out of quarantine. And all of that is predicated on the person you're talking about, the child staying without any symptoms. And if they develop symptoms, it's a whole different pathway. So you can see why you need individual advice from, and that what it's so hard about being childcare providers and teachers, school nurses, is the advice is given to the family on the phone, and then they interpret that to you, which puts you in a hard spot because you're not getting it directly from the contact tracers. So if there's some specificity here, I'm sure Sally and the team would be very happy to try to sort out what's happening, because it is hard.
Thank you. If a child receives a positive rapid COVID test result, what type of in-house action should a program take while they await the results? Programs seem to be getting case-by-case conflicting information and also several false positive results on rapid tests. Best advice.
So
Let's play this that you guys answer, and then if you need me, give me a wave, because I'm such a chatterbox. So you need to zip my. Nate
gave us a little bit of a lifeline with this one. He checked in with some of our epi people, and while the PCR is the gold standard, they said that the antigen test performed very well among symptomatic individuals. And if you look at the data of Vermont results, that 96% of the time, the results will match each other with the PCR and the antigen if someone is positive. So as much as we want the PCR for that confirmation, the person should still be treated as a positive case. Okay. Rena, take it away.
Yeah, absolutely, 100% true if the child was tested in the setting of being symptomatic. So that's what Molly said at the beginning, and this is such an interesting evolution. You may have heard me speak for months about antigen tests being sort of second class to the PCR, but it's, as the technology gets more and more refined, they've become quite effective in detecting COVID in people with symptoms. You have the viral load in your nose. The antigen tests are accurate. So we're heading toward a world where we're going to be doing more and more antigen, but the current protocol is still the confirmatory PCR is, recommended and unlikely to be removed. But if you throw an antigen test into a whole bunch of asymptomatic people and that comes out negative, it's, then you have a whole journey of deciding why did you do the test and what is your, how confident are you that was an accurate negative. So that's where you would need much more clinical advice. You can't be using antigen tests to determine asymptomatic people's negativity very easily. The one caveat to that is in test to stay, it works because every day we're testing the antigen tests of kids who have no symptoms, and it feels like it's safe enough for that one day that they can function in the school if that comes back negative. So that's another talk, test to stay, but it is this, you're going to watch, and that you've asked about information sharing and how you stay on top of all this. I think we're going to see a lot about vaccine in the next few weeks to get the 5 to 11-year-olds vaccinated. And then you're going to start to see over the winter shifting what type of tests work, where's the access to these tests. And I'm hopeful that you as the people caring for younger children are going to have much more access to tests. And there'll be more systems for that. Maybe every human will have tests at home to do and all of that. So stay tuned, but we're going to need pretty tight protocols so you're not stuck trying to interpret.
Okay, so there are two things I just want to throw on the tail end of your answers. Thank you so much for that. So Nate has been dropping some links into the chat box for everyone. One is a follow-up testing guide, one is for contact tracing checklist, and another one is for finding your community resources. And he put a few notes. So just make sure that you can have access to those, click on those, and then you can check them out later. Here's a question that has come up in my work in the field, and also has been raised in a couple of different ways here, and that is, are there going to be, so speaking of access, are there going to be more clinics available for early childhood educators for their boosters? It has been extremely hard to get a Friday or Saturday appointment for booster shots. We need weekend appointments to guard against teachers reacting the next day. Our programs are spread so thin, and we won't be able to cover for all of our teachers as we do not have the staffing available. Programs would need to close for a day or two, which is, makes challenges for both program and children and families.
That's the perfect feedback for the health department team to bring to the vaccine planners. And I can't tell because of my screen if Monica's still on, but thank you, because that's exactly the feedback we need. And I say we, because I still pretend I work at the health department in case you haven't noticed, but that's the royal we for Sally and Monica.
Okay, so we can pass that on.
Yeah, that has come up around the state with a lot of us who are doing the community and program support work here at Let's Grow Kids, and I'm sure, even in my personal conversations in the community. So I really appreciate if you can call that to someone's attention. Let's see here. Would it be best practice to exclude a child from attending a program whose sibling is identified as a close contact? And that sounds like that contact of a contact. They were identified as a close contact at a public school, but shall we wait until that sibling's test result is known? And I heard you say do not exclude, but do you just want to go a little deeper here?
So again, it goes back to they are a contact of a contact. So at that point, it's removed enough that we do not feel that the science has shown that they do not need to be excluded. I know they're saying if waiting to see until the sibling's test results come back, if the test result comes back and the sibling is positive, that obviously changes things because then the child would be a contact. But at this point, they are a contact of a contact, and it really, the risk is not substantial enough to exclude the child.
Okay, so there was some follow-up on that in the Q&A box. If the sibling is negative, the child who's enrolled in this program can return to care. But if positive, then would that child be required to be tested in order to return?
That would become, they would become a contact. So then that would be working with the contact tracers, and they would
Okay.
be able to give greater guidance.
Okay, that's important. Thank you. If a vaccinated household member has been exposed and tested negative, and then within 4 days becomes symptomatic and gets tested again, do other household members need to quarantine while that member awaits the new test results?
Well, I'll just jump in to say that this level of detail is extraordinary. You got, and I know this is what you deal with every day, so I just wanted to take a moment to take a deep breath with all of you because, again, need more info. So a vaccinated person who's getting tested, sounds like that person's getting tested for symptoms. That's something, so that's an entity. But then the child, if they have symptoms, should be excluded. And then whether they get tested or not is really based on what are their symptoms, how long, and because you're still presupposing there's something going on with that vaccinated adult, which despite all of the concern about breakthrough cases, it's still very unusual to track COVID when you've been vaccinated. So I think one of the things that's I know from working with you a long time, the absolute hardest part of your job is excluding children who are ill. And as you know, that's the cornerstone of this whole thing. So in a perfect world, you would not have to work through allowing anyone who was ill into your program. But I know in real life, you get a lot of pressure from parents, and we don't have the right social policies in place to allow families to be home with sick children. So, but I still just want to impress you upon that. So no one needs to be tested while other people are waiting for tests unless they're put forth as a group of close contacts. So, but if it's just people wondering if they have COVID for symptoms, we would need to know more about the child's symptoms to determine if they need a test.
Thank you. And it's interesting because some of these questions are coming in like, I know program and or the person. So I'm thinking, oh, this is a person who's operating a registered home. And I'm going to guess that this is like, a lived experience here. So it really is
completely
individual.
Can I, Brenda, can I just interrupt for a sec? Because Nate is working so hard in the chat, but I want to make sure he knows that no one can see the chat.
So
right? The chat has,
yes.
Okay.
I just would like to address that as well. So yes. So, not everyone can see chat. So, and some of you have mentioned that in the Q&A lineup here. So I want to reassure you that we are going to, yes, Nate, thank you for trying. He's making valiant effort and sending all these great things. And I'm telling you about them and you can't see them. But in fact, we are going to capture every single one of them and we'll send that out in our follow-up email. So you will have every single live link with all of the information that Nate so diligently is sharing with you. Some of those are the direct sources of the information that Molly and Katie and Brina are sharing with us. So let's see what else we have here. Do you know anything about boosters for 16 and 17-year-olds who got Pfizer vaccine? Or I would say any previous vaccine. Maybe that's the only one they could get. Now I forget. Anyway, do you have any information about boosters for 16 and 17-year-olds?
I personally do not have any information, Brina. I don't know if you do, but I have not heard anything.
You mean
is it
coming? So
recommended,
there's no recommendation yet that we boost 16 and 17-year-olds. As you can see, though, there's constant analysis of the vaccine duration, and the current recommendation will likely change over the next several months about eligibility for the booster. And I wonder if that will lead to recommendation for 16, 17-year-olds, but it may be different timeline, and it may take a longer effort because we wait longer with pediatric analysis of clinical trial data.
Thank you. What is the recommended protocol for kids with HFM? We are seeing several cases of this and wonder how long kids need to stay out, and can they become reinfected?
Are you talking about hand, foot, and mouth? This is, if that's true, this is an exciting moment. Is that what you mean by HFM? I think it's, my dog is very excited about HFM as well. I haven't thought about it in a while. Let me look it up. But remember, hand, foot, and mouth is caused by a Coxsackie virus that you're actually infectious before you have the lesions, which makes the infection control piece of your childcare very challenging because the exposure would be before you knew that the child had HFM. If you're talking about hand, foot, and mouth.
That's what I assumed, but I'm
okay,
also
good.
not
And
a nurse.
Well, and after you've erupted into the hand, foot, and mouth, the child should stay out until well. And when I mean well with hand, foot, and mouth, it's really the resolution of the fever and able to take oral, because one of the highest places for the vesicles is in your mouth, which leads to dehydration. So we can send you some fun stuff on that. That's a nice, whew. Boy, I sure do dream of a time we're talking with you about other infectious diseases. And that's why my dog's barking too.
Harkens back to the good old days. So when that was our biggest annoyance or frustration. So there's a question, will test stay be extended to preschool 3 to 5 year olds? And I saw on one of the slides that you presented earlier that there are several considerations being developed between the CDD and the Vermont Department of Health. And is there anything else that you could say to
that? I'm sorry, can I help with that? It's you're asking about new recommendations coming from CDD?
It's about the test to stay program and how it's really developed for older kids at this point. But I did see in one of the slides that there was some talk between CDD and VDH.
Yeah. So take it away.
Well, the test to stay, I think we addressed earlier that it's really a protocol to keep students over age 5 in their learning environments based on their ability to mask, and also the students are asked outside of school to essentially quarantine. So it's really just a daily antigen test to keep close contact coming to class. I'm so sorry about Molly. So it has not been tested. But what I think that slide meant from Sally is that other testing strategies for childcare are on the table, including sending parents home with tests or making antigen tests more available, or helping you manage the finding out who has COVID.
Yeah, thank you. Yeah, I think the question really was getting at, like, so it might not be called test to stay in early childhood, but something that would perhaps work in a parallel way for early childhood programs. So let's see. So some questions we ask you, and we understand that you might not actually be able to answer them. So I'm just going to pose this one. So parents are already asking programs if the Pfizer and Moderna will have the same 2-shot requirement. Do you have any insights or knowledge of that?
So currently the Pfizer is going to be a two-shot vaccination.
You knew how to answer it. Yay. Because sometimes we do pose questions. Heads up, new people. Sometimes we pose questions and you say, I don't know. Okay, we get it.
But yeah, 2 doses separated by 3 weeks. Yes, Brina? So.
Okay, cool. Thank you. Let's see here. So staff have asked if the mRNA vaccines can simulate other viruses, because we have had an uptick of the varicella. Is it varicella?
Varicella.
Varicella, thank you.
No.
Hmm.
If I'm super interested in hearing about that. So, meaning you've seen cases of chickenpox or uptick in people getting the varicella vaccine?
Oh, I don't know. So the person who entered that question, if you could clarify, are you talking about the varicella vaccine, or are you talking about the COVID-19 vaccine?
Varicella here. And remember, just because we're back in general infectious disease land, my favorite lane, varicella is a reportable disease. So if there was any kind of increase in the cases that we would expect to see in Vermont, the health department would be aware of that. So that would be of great interest to me, but completely unrelated to anything going on the vaccine front, unless we did have during the lockdown, we had a decrease, very brief, but where children were getting less in-person well-child visits. And at that point, there was about a 5% decrease in routine childhood vaccinations in Vermont. So, there's a hypothesis there, if we really are seeing chickenpox, that we might be under vaccinating briefly during a pandemic. So I'd like to know that.
So someone thinks they heard you say that it's okay for children to return to care after negative results, but they might still have symptoms. Okay, no.
Definitely not. I know what this is getting. And again, like caring for our children, our perfect world pre-COVID was very much disrupted by lack of social policy to protect workers. So you had a lot of kids with runny noses and cough in your care. So I think people are trying to get back there with a negative test, and that's not our intention. You have to be well to go back to childcare. The negative test is helpful to know, whew, thank goodness that wasn't COVID, but you still have to get better and head back.
Yeah,
I'm sorry if that came out differently.
Well, that, it was my hunch that it was probably just misheard, but it's always good to clarify these things. And I think you guys are the best people to do that. So it's interesting now that we've put some like varicella and some other things on the table. A number of people have said, we've had some RSV running through our center. Why do you think that we're seeing such a high number of cases this year? Other folks have weighed in on 3 cases of chickenpox in the past 3 weeks, and an uptick in chickenpox and shingles, even in young children, and they were vaccinated. So, just sort of any thoughts on what's going on there, and then we'll move to a couple more questions before we have to start wrapping up.
I don't have a lot of thoughts. I'm certainly interested. I would wonder, so I think you're saying these are vaccinated individuals getting chickenpox, which is, we see that. There is breakthrough, but it's rare. So that might need a deeper dive with either the health department team or local pediatricians to think about what that's about. And then RSV, definitely. Not only are we seeing more cases, it's earlier. There was a time when the curve of RSV coming into Vermont was definitely a post-holiday January peak, and we were seeing cases in August and September. So I don't really have a hypothesis about that, except that we saw none last year when we were, pre-vaccine for older people, and a lot more mitigation strategies, especially not gathering, and maybe just a scooch more attention to masking and distancing. But I don't know from an infectious disease perspective what people think about that. I do know it's true. Lots more RSV.
So can kids get their COVID vaccine and flu vaccine at the same time?
Yes.
Yes, please.
Yes,
Yeah.
please.
Yeah. Get them flu and COVID vaccine.
Yeah. Okay, great. Good answer. And So we're going to have one more question that we're going to have a brief answer for, and then we'll just wrap it up here. And I'll just remind you that any, anything that we feel like maybe we'll send some follow-up information out. Sometimes we have a whole host of unanswered questions. I think that's not happening today, which is great, but we'll still send you resources. So how long would be reasonable to have improving symptoms before another COVID test is recommended for a child? We have seen runny nose and cough for a month after a negative test, and their pediatrician says no need for another test. We asked again and they said, oh, it's nasal congestion. This keeps things spreading for staff and others if we have no reasonable time for improvement. Help.
Oh,
Ladies.
yeah.
I
Oh,
think
Brina, I was
it's
going
your
to plug that
medical
to you.
team.
It's so frustrating.
I don't like that story. That's a frustrating story on several levels. I mean, I think, a negative COVID test is good. And then if symptoms resolve and come back or persist, I do see a place for testing again, especially during time when we're still seeing pretty significant community spread. That being said, I love my pediatric colleagues, and I don't like to speak about clinical decision making on webinars because I don't know the specifics of the case. So I think that was Andrea asking. Andrea, I really like teams and team-based care, and I like people respecting each other's expertise. And I wish you could just talk with them and say this is hard. And again, having a child with chronic nasal congestion in your program is, you can make the decision that doesn't fit with your infectious disease protocols, right? So, but then you need the medical team to, if they want to come in with an alternative diagnosis that it isn't infectious, I would encourage that communication. So that's kind of a half answer. Yeah, go ahead.
Sorry, I was going to say we're back to that key thing that we talk about every time, and that's the communication piece. Communication in every direction with all the parties. So we do have to wrap because there are a lot of early childhood educators who need to get back to their kids in classrooms and staff, and you need to get back to your work as well. So thank you, panel of presenters. Thanks to each one of you. We appreciate your time and your expertise, and we look forward to future conversations, always helping us to keep Vermont's children safe. And Sally, we wish you joy in your retirement. Thanks to everyone who joined today. Please join us. Bye. Please join us again. You can join me again tomorrow at the same time for considerations and strategies on how to maximize the ARPA funds that you're going to get. So you can register at a link that Raya just dropped into the chat. You can always reach out to us about many things at letsgrowkids.org. Have a beautiful afternoon.
Thank you.